adequate network again, and those conversations happened.
Very good. Okay, I yield back, Madam Chair. Thank you.
The gentleman yields back. I now would like to recognize the gentleman from Oregon, Mr. Schrader, for his 5 minutes of questions.
Thank you, Madam Chair. Dr. Zaafran, curious about evidence with the frequency of surprise billing. I mean, is it a big chunk of the marketplace reimbursement, or is it a small piece of the reimbursement puzzle? And does it vary dramatically from network to network? And does it vary geographically? We've heard some testimony.
Thank you for that question. And, first of all, one out-of-network bill to Ms. Wilkes is one too many, and that's why we have to address that. But the overall incidence of out-of-network providers is actually fairly low. It's in the 5 to 10% range. I think nationally, if you look at all the different services provided, it's 80 to 95%. So there's a little bit of variation there. But again, going back to the point of preserving the in-network providers or physicians that are already in network, we don't want a system that's going to disincentivize carriers or incentivize carriers not to continue those networks. Right. Again, we started to anecdotally see that happen in California. We've seen the exact opposite happen in New York, where you had 20% of emergency room physicians out of network, and it went down to 6.4%. So the evidence is out there, shows that with a good arbitration style that is fair and expedited, you actually can have the effect of maintaining that in-network market, but adjudicating the out-of-network market in a fair manner.
Mr. Nichols, would you agree with those comments and the relative states and the results we're seeing?
Absolutely, and I would throw Oregon into the mix too, which, as you know, the law is new there, and also I think it's reflective of what New York set up, what Texas have. They're all a little different.
Can you bring your microphone closer?
All right, I keep doing that.
Thank you.
I think the arbitration model, again, the data coming out of New York is very persuasive that it works. I don't think it's going to be the situation where there's some like really high amount and some reasonable amount, and to think that the really high amount is going to win. No arbiter is going to pick the really high amount. The reason we have arbitration in New York that's successful is it brings people toward the middle. A lot of people settle them beforehand anyway. So I think those approaches are the best, and I know our members were supportive of the Oregon law. I know it's brand new. More data needs to be, more data needs to come forward.
Ms. Thornton, Mrs. Zaafran talked about the incidence of surprise billing, and certainly one is too much. I get that. But I want to get a feel from an economic standpoint, what percentage of the insurance industry's healthcare business is resulting in paying these surprise billing?
Sure, not a problem. And back to network adequacy, I just wanted to mention that Texas has one of the largest rates of surprise billing in the country, even though it has a robust network adequacy provision. But back to the economic impact, I included some data in our testimony that was put together by Avalier as New Jersey was considering what changes to make as part of its changes to its out-of-network billing law. And it really shows there is quite a large economic impact. It could be as high as, in the study showed, 4% of claims could be as a result of a benchmark that is based on bill charges and is a higher amount than some of the other proposals that are out there. So definitely hitting consumers in their pocketbook in terms of that economic impact.
So it seems to me like there's this dynamic tension between making sure that we have a robust provider network. The insurers are encouraged, frankly, to reach out to providers, and at the same time make sure that providers don't get to raise rates so that the consumers at the end of the day end up paying higher. So there's going to be this dynamic tension because in the long run, the more robust provider network, in my opinion, market forces will drive those costs down. But we've got to make sure we don't injure the consumer here in the near term. The other big piece that's out there is transparency. I mean, it'd be interesting to get real good data. I'd ask you, Ms. Thornton, to talk with your insurance plans and get back to me and the committee on what percentage of your business is surprise billing. Are there different subsets? Some people testified that there may be certain specialties that it occurs more frequently with. Some testimony would indicate that, well, no, it's all pretty equal. It would be very helpful for the committee, I think, to get that information so we can get perspective on that. My standpoint, I think the solution is a lot simpler than what we're making it out to be, where you can encourage a robust network and make things happen. Take the patient out. Everyone agrees with that. Ms. Wilkes shouldn't have to deal with these issues. This is insurer, provider issue. And, I think if you just have the insurers providing a little extra, making sure that they have a robust network, we're not going to have this problem at the end of the day. So appreciate everyone being here, and I yield back.
Gentleman yields back. I now would like to recognize the gentleman from Oklahoma, Mr. Mullen, for his 5 minutes of questioning.
Thank you, Madam Chair. I want to talk a little bit more about, Ms. Thornton, about the surprise billing. Can we get a little bit more specific about what the surprise billing ratio is in rural parts of the country, specifically maybe in Oklahoma? And Ms. McAndrew, I saw you just kind of wiggle in your seat like you might have some of that information too. So I don't care which one wants to answer that.
Thank you for the question. Yes, over 10% of inpatient admissions in Oklahoma result in a surprise bill, and that's the case too for other rural states represented on the committee, like North Carolina, like Kentucky. And so I think it is important to recognize that already there are instances in rural states where we have out-of-network providers. And I think, we talked a little bit about how providers want to be in network, but there's not, an equal incidence of surprise bills.
What's the biggest issue with the out-of-network? I mean, we've seen this huge increase of out-of-network billing over the last few years. One, what's caused that, and what's the biggest issue on that?
Well, I guess what I was going to say is that we've talked about how providers want to be in network, but I think for certain types of providers, people want to be in network, but not as much as they want to get paid.
Well, but that's
far,
what the
far
point
more
is.
than,
People want to be a network only if the provider provides what I'm asking for them to pay me back.
Yeah, insurance,
and then they have another
certain providers
choice.
want to be in network only if they can make very high rates.
Right, and then they have a choice. Well, I don't have to be a network because I can still have access to the hospital. So why do we see that big increase now? Why are we seeing this big increase on surprise billing?
So I would say that we haven't always had great data on surprise billing. So the data I've seen hasn't necessarily indicated an increase because the data we have on the surprise billing problem tends to be newer data in general. And as I indicated, this is a problem that we've been working on for many years. And so it has been a long-standing problem.
Well, let's talk about the data. You were talking about one size doesn't fit all. And Mr. Nichols, you were kind of echoing that too. I do agree with that to some degree, but I do also understand job costing. And as small as my company is, I can still go back through it and find out my average costs are on certain jobs because some of them are repetitive. Is that information not out there? I'm not big into arbitration for sure, but there should be a fair road someplace. I think Ms. Thornton or Mr. Nichols, you talked about in the middle with arbitration of finding out where it is. Maybe that's the legislation that we're looking for, that we can provide that data. If you can't provide the data, we can provide the data and say, I know what the average cost of a hip replacement is. I know what the average cost of getting 2 stents put in. I understand there's special circumstances that take place. I understand what the average cost of delivering a child is. I've got 5 of them. I can get those average costs, and is that the starting point of coming up to where the network and the provider should find somebody?
I'll take a stab at that first. I think that there are some instances where getting the average cost is easier. Hip replacement. If there are no complications.
I get that. There's standard operations, there's non-standard operations, there's standard jobs that my company does, there's standard jobs that they don't do. I get the per hour cost, and I also get the idea about bidding jobs.
Right.
And that is called flat pricing, upfront pricing. You can't tell me we don't have an average cost of what it takes to do as many surgeries as we do inside this country on as many different parts of the body. You can't tell me we can't come up with an average cost on that.
Yes, in most instances we can.
Okay, then those are the most instances we're talking about. The special cases are special cases on themselves. We can solve the most cases, though. For instance, this finger right here, not that I'm doing anything bad, all fingers are up. It just happened to be this finger right here. In Louisiana, I cut this finger. $11,000 is what it cost me to get stitches put in that finger. This thumb, right there, $150 at my local emergency room. Somebody explain to me the differences in that? Both of them were, by the way, by a knife, which is why I don't carry one.
Well, I can tell you that from the physician standpoint, for emergency room physicians, for example, the average weighted cost of every visit is about $155. That's the average across the board for all services provided, and as was indicated.
Okay, then that's our starting point.
So you've had.
So
you know,
why is it that we
1.05?
can't find an average when we start negotiating prices?
My point is, though, it's not as high as folks think it is.
Listen, your point I get, but the billing says it is. So your point, you can say whatever you want to about your point. The fact is, the bills that come in our mailboxes say they are very expensive. So I think it was Dr. Burgess that said, if you don't fix it, we will, and you guys probably won't like it. And that's the road that we're going down, because we can get access to that data. We can find that average cost. And if you all don't want to solve it, then we're going to. All we're saying is do it, solve it. With that, I yield back.
Gentleman yields back. We have a vote that we need to go to the floor to take, but before we recess, I want to recognize the gentleman from California, Mr. Cardenas, for his 5 minutes of question.
Thank you very much, Madam Chair, and I appreciate the witnesses sharing your perspectives, and Ms. Wilkes, your personal story. Thank you so much. I'm glad to hear that your son got the critical need that he needed in that very moment. I do have a question for you, Ms. Wilkes. When that provider group sent you that $50,000 bill, was it easy to understand what you were being charged for?
No, as I mentioned earlier, it was just a dollar amount. There was no specifics as to what services were provided.
Okay, and what was the process that you felt was available to you, or how did you figure out how to deal with that, and what options you had?
So we called the billing, the person that was giving us the bill, the entity that was giving us the bill, and they were not willing to work with us on a payment plan. It was an all or nothing situation. And as we began asking questions, that's how we found out that they were a third-party provider that was out of network in the facility that was in network. So it really just was butting heads. We never could come to a solution to be able to even begin to think about paying that off.
Okay. I mean, I have grandchildren, and I still have children on my plan at home, and I was thinking maybe we need to make T-shirts that we need to put on our loved ones whenever they go to the emergency room or to the doctor or what have you, and it says, only in-network provider, exclamation point. By the way, please don't let me die. Happy face. I'm not trying to be funny. What I'm saying is Americans should expect then when they go see a provider, whether it's an emergency basis or not. I have a son who's on my plan, and he went out of network. We knew it. I, as a policymaker, didn't know to ask more tertiary questions about how much each one would be. Luckily for me, it was associated, in this case, I think it had to do with associated with a local university that some of my fine colleagues have been to, et cetera. And, you know, it was another $500 here, another $500 there. Thank God there were no more zeros on that. My son had already met the deductible for the year. So that was over and above what my plan had said, okay, you're done with your deductible. Every time you go in plan, then you're gonna be okay, family Cárdenas. What bothers me, and you're hearing my colleagues, Republicans and Democrats, saying we need help to understand what's going on out there in the real world. Otherwise, we're gonna provide a solution, and you're not gonna like it. Legislators collectively aren't necessarily known. Our track record isn't that great of hitting the nail on the head when it comes to fixing big problems, unless we get tremendous help from experts so that we can hopefully narrow it down and actually make good policy solutions. I have a question. My understanding is since the 80s, they may have called it something differently. Since the 80s or so, there have been this surprise billing issue facing American families. This isn't just 5 and 10 years old. Is that correct? I think, Ms. McAndrew, can you shed some light on that?
That is correct. networks, from our perspective, are a necessary function because they have an ability to rein in costs for consumers. But of course, if you have a network, which was part of the managed care revolution that we saw begin in the 80s and increase in the 90s, you can get either in-network care, you can get out-of-network care. So if you end up inadvertently going to an out-of-network provider, you'll get a surprise bill. And I mentioned that this issue is something that our organization, Families USA, has been working on for over 20 years. We published on it in the early 90s. So this is absolutely not a new problem.
Okay, so this has been going on for decades.
Absolutely.
And has anybody here been at the table before Congress to talk specifically about this issue over the last, 40 or 50 years? Oh, you have.
Well, not
Dr.
40,
Zaafran?
50 years, but since 2009, actually, we've been addressing it in Texas, and it's been a progression. Of course, we addressed it in New York, but
So at the state level, but
not at the federal level. Correct. Well, there's the greater of three standard that the federal level has actually had, and it's been in place since then. It's
Since
offered
when?
a certain level of
Since roughly when? Decades?
It's been at least a decade.
Okay,
I wouldn't say
got it.
decades, but
Okay.
maybe about a decade.
Right. Okay. The reason why I want to point that out is because I hope that the dialogue doesn't get mired into, what caused this. It's been going on long enough. We got to figure out how to remedy it. And I think that if we keep clear heads and we are able to focus on the common denominator, to me, the common denominator is the patient. That's the common denominator. And then try to figure out how do systems fulfill their obligation to stay afloat and provide services out there in the communities. I'm sorry, I overstepped my time. Sorry about that, Madam Chair. I
It's
yield
always
back.
nice to listen to you, Mr. Cardenas. You're wonderful. Gentleman.
Reserving the right to object.
No. The gentleman yields back. We have a vote on the floor, and I don't know if there will be any subsequent votes to the one that's on the floor. If there aren't, I think that we all have a 20-minute break at least, and I hope we can just, that's what the case will be. So we'll recess now. We'll go to the floor, take our vote, hoping again that it's one to return. But if it's longer, you just have to be flexible. Ask you to be flexible. So the subcommittee will recess. I want to thank the witnesses for your patience, although I'm sure you welcome the break. As soon as one member returns from the floor, we'll start back up again. So you can continue your chats. Maybe you'll come up with a consensus at the table while we're waiting for members to return. Wouldn't that be wonderful?
Please pass your papers forward.
Right. All right. The subcommittee will come back to order. The chair would like to now recognize the gentleman from California, Dr. Ruiz, for his 5 minutes of testimony, and one of our members that has worked very hard to come up with a solution to what we're grappling with on it's so ludicrous that this could ever be called balanced. It's not balanced, it's totally out of whack billing. But I want to attach that compliment to Dr. Ruiz's name, because he's worked very hard since the beginning of this year on the subject matter. You're recognized for 5 minutes of questioning.
Thank you, Madam Chair. And the reason why I've worked so hard is because, as a physician, we try to eliminate the pain and suffering and anxiety from our patients. And then you find out that the patients are getting a surprise bill that is adding to the anxiety, which only makes their health worse. It only makes their health worse. In addition to being concerned, as Ms. Wilkes was, about her son, she was also concerned to tears and the anxiety of going bankrupt, or what do you do and how do you cut costs? That's an outrage. It's unconscionable that families are going through what they're going through. And that's the number 1, 2, and 3 reason why I set out to find this solution. We have to close every loophole imaginable so that patients are not stuck in the middle of this dispute, so that patients don't have to decide between, staying in their house, renting an apartment, paying their bills versus paying their medical bills because of a life-threatening situation for their child. We need to keep patients out of the middle. And quite honestly, those state models, even with arbitration, don't do enough. There's always a fine print. There's always a window that a patient has to go through to mail an envelope back or make a call, and if they don't understand, then they're the ones that are not going to have those protections. And I'm concerned with this current bill that there are, like you, Ms. McAndrew, that there are too many loopholes that still allow providers to find a way to say, no, it's your fault, you didn't see the sign, or it's your fault, you didn't make the effort to look at the online list, or it's your fault because you weren't aware that this hospital or these providers were out of network. In fact, asking an emergency department patient or an in-hospital patient if they consent to be seen by the on-call physician if they are out of network doesn't work in the real world. And it takes somebody who cares for patients, who actually has cared for patients, to understand that. Because those patients will most always choose yes, because they're under duress, or because their care will be delayed, or because they will not understand the implications. And if they consent to yes in this bill, then yes, I will be seen by the anesthesiologist because I've been in the hospital too long. Then that allows the physician to balance bill. It's not good for patients. And to expect that a physician who's on call that night, who doesn't deal with their bills or doesn't deal with being in network or out of network, that's a billing department issue, and they got 15 different people, to expect them to then just say, no, let me check right now to see if you're in network or out of network, or if I'm in network or out of network, is not based in reality or in the real world. So creating a loophole where, quote, adequate information was provided, right, that somebody would say that, gives a way to balance bill. It will put the responsibility on the patient to read the fine print or be aware of all the ways the providers can say they were made aware beforehand and it was the patient's fault they didn't read it or understand it. And that needs to end. And the bill that I propose, Protecting People from Surprise Billing Act, has the most robust patient protections out there from any state model or any proposed bill. Because that is my number one, number two, and number three priority as someone who cares deeply, who's devoted my entire life during the arduous training to become a physician, to do everything possible to relieve pain and suffering and promote wellness in everyday Americans. So the second part is, how are we going to solve this dispute? And we need to understand that we need to pick a system that is fair, that we're not picking winners or losers, that we address the underlying problem. The concern is cost. So Dr. Zaafran, talk about costs, inflationary rates. What does the evidence show in terms of the models that are out there?
Thank you, Dr. Ruiz, and thank you again for the effort that you put into the bill that's out there. Well, again, if you look at the data that's out there on New York, which has been out there for many, many years, the inflationary cost with that dispute resolution process has simply not been any different than the inflationary cost out in California. I believe the number is somewhere along the lines of 6 to 7%, not 67, 6 to 7%, and it's been the same whether you have a benchmark process.
So you're
in
saying
California.
that there is absolute data showing that an arbitration does not increase inflationary cost? Because otherwise, if the data were otherwise...
Excuse me, the
I would
gentleman's
choose
time
another
is
place.
expired.
Thank you so much for your
Yes,
graciousness.
thank you. Now I'd like to recognize the gentlewoman from Indiana, Ms. Brooks, for her 5 minutes of questioning.
Thank you, Madam Chairwoman, and I apologize, I've been going back and forth to other things as well, and at this point, I yield my time to Dr. Burgess, Ranking Member.
Thank you. We're so glad you came back. Ms. Wilkes, I'd just like to ask you if I could. There has been state legislation passed in Colorado, correct, dealing with this. How would that have impacted your situation when your son was born?
Thank you. I actually am not aware if there has been legislation passed in Colorado, to be perfectly honest. But depending on what that legislation said, it maybe would have prevented us from having the bad credit rating that we had. Quite frankly, it's not just surprise billing. In my family's case, it's billing overall. I mean, high-cost dollars. We've gone to arbitration several times to deal with debt to the hospital. So it's not just this.
Because of that initial episode or subsequent?
It's a chronic disorder.
Right.
I mean, you know, we're not going to get rid of it, so there's going to be cost. He's about $1 million a year kid.
Which is why the hope for the gene therapy is, and when we talk about how do we price that, it does have to be in the context of what is it costing us to do nothing, and clearly your case, the cost is almost intolerable. Dr. Zaafran, you were answering a question from Dr. Ruiz a minute ago, and clock ran out on you all. I'm very sensitive to that because it runs out on me all the time. But do you want to continue your discussion just a little bit?
Yes, thank you, Dr. Burgess. No, I was just reiterating that in New York, where they have had a New York arbitration process, a dispute resolution process that is robust and expedited, that there has not been any difference in the inflationary costs as compared to other states. It hasn't increased, it hasn't been any different than it has been before, and it has resulted in a decrease in the out-of-network providers.
Mr. Gilfand, you kind of indicated that that was not an acceptable solution from your perspective. That data that now Dr. Zaafran has shared with us, is that good news from your perspective, or news that doesn't necessarily move the needle one way or the other?
Dr. Burgess, many of the comments that you've heard today are without context of what the markets looked like before these state proposals were brought forward. So specifically in Texas and New York, the question is, could things have possibly gotten any worse? When we look at arbitration models, we know that outside counsel charges us $500 an hour on a good day. We know that the filing fees for many of these arbitration groups are $1,500 per party per claim, right? So we beg you, spend healthcare dollars on healthcare, not on attorneys.
Can I just ask you about that? Now, I've been told from my counterparts in the State House that the fact that arbitration is available means the parties move to an agreement prior to getting to that arbitration phase. Just the fact that it's out there means that they are going to talk. Is that something that you've seen?
Dr. Burgess, we would defer to the Congressional Budget Office that has looked at several proposals and said that if you change to an arbitration model, it increases costs by $5 billion. That money will be paid by patients.
Yeah, Congressional Budget Office is always high on my list of my favorite people, but Dr. Zaafran, can you comment on that? And Dr. Frieden, I'd like you to comment as well.
Dr. Burgess, the cost of arbitration in New York is $300 per arbitration, and it's split evenly between the insurer and the physician. So, and it's a 2-week process that is all entered electronically and it's adjudicated right away. So this cost of arbitration being excessive, again, the data in New York and the way it's going to be in Texas, it's a very low cost. It's split between the insurer and the provider with very specific guardrails. And again, in Texas, what we did is we referenced the previous contracted rates, which is basically saying that you don't have to have just charges out there. There's a teleconference that happens before arbitration that allows for both sides to sit down at the table and try to come up with a fair payment that they both agree on. If they don't, that final offer is what goes to arbitration. That final offer could be your previous contracted rate before the insurance company dropped you out of a contract. And so that allowed in Texas the fiscal note, the score, to come down significantly.
I see. And Dr. Frieden, you have a thought on that?
Yeah, I just want to point out that in New York, in 7 million emergency department visits in the year, 849 cases went to this dispute resolution process, which is about 0.1%. So the process in New York, at least, has worked in that the parties are resolving their dispute before they even utilize the dispute resolution process.
Thank you.
Thank you, Madam.
The gentleman yields back. Now I'd like to recognize the gentleman from Vermont, Mr. Welch, for his 5 minutes.
Thank you, Madam Chair. Vermont does have a law since 1987. It's banned balanced billing in the emergency department settings only. And while that addresses a major issue, it still has a number of holes. It doesn't do anything to prevent surprise bills from anesthesiologist, pathologist, or radiologist. It doesn't protect Vermonters who seek care in other states, and many of our Vermonters get care at Dartmouth-Hitchcock right across the Connecticut River, which is in New Hampshire. And finally, the bill doesn't set a rate of reimbursement. I want to ask a few questions, but first, this whole surprise billing situation, I think of Dr. Bouchon, is reflective of how it's so opaque what the billing mechanisms are in the healthcare industry. And consumers have no power. And what it feels like on the outside is that all of the providers who are seeking to get reimbursement at the maximum rate and make their claim as to why they need that, the lack of transparency, in fact, works to their advantage. And this is just one manifestation of it. But the challenge for a consumer is they are totally powerless. So the question I have fundamentally is, should the burden to bear the cost of this lack of transparency and opaque billing system be on the consumer who shows up sick and powerless to affect anything, or should it be on collectively the delivery system? And that would take a lot of cooperation and probably a lot of legislation. But I don't believe it should fairly fall on the shoulders of a consumer who shows up and is absolutely powerless and had nothing to do with creating the mess in the first place. So just a few questions. I'll start with you, Mr. Nichols. How do you see the proposed legislation, the Pallone-Walden bill, affecting our situation in Vermont?
Well, I think it would actually address one of the problems that you currently have in Vermont. It does address, of course, the emergency situation, which you have protection for. That bill also reaches into situations where a consumer goes into a facility that's in network, and they knew it was in network, and they did it all in good faith, and they got a bill from an out-of-network physician. That situation, which apparently is not taken care of in your state law, would be taken care of by the Pallone bill.
Okay.
So that would be an improvement. Now, we have some concerns about the Pallone-Walden bill, but on that case, it would be better for consumers than what you have in Vermont.
Okay. Ms. McAndrew, what about the situation for Vermonters who get their care across the river in New Hampshire? And that's about 40% of people in the region of Vermont that I live in.
Thank you for that question. One of the reasons we think a federal solution is ideal is that we believe wherever you live, wherever you receive care, you should be fully protected. We shouldn't be relying on a patchwork state-by-state system for protection.
Okay, and while consumers are seeking specialized care, they're bombarded with an enormous amount of information dealing with being sick or injured. And how do we ensure that patients are informed in a clear and meaningful way, but one that doesn't put an undue burden on providers? Do you have any thoughts on that, Ms. McAndrew?
Yes, well, I think one of the ways the legislation recognizes that consumers shouldn't be bearing this burden is that in facility-based provider situations, the legislation actually doesn't rely on notice requirements. If you are getting care from a facility-based provider like an anesthesiologist or emergency provider, my understanding of the legislation is that the protection actually is automatic.
Okay,
The 24-hour notice requirements, as I understand them, although I do believe longer notice should be required, are applying in non-emergency situations or non-facility-based providers. But anything that can be done to make it even more automatic, so we are getting rid of any phone calls, any emails, any going back and forth between insurers and providers is the ideal solution.
Thank you for that. I want to yield my last minute to Dr. Ruiz, who's been a leader on this for us.
I
Thank you.
appreciate it. Oftentimes during negotiations, insurance companies have a take it or leave it approach with no communication and no negotiation. Why, Dr. Zaafran, what makes baseball-style arbitration so appealing to states to want to impact a fair system?
Thank you, Dr. Rees. Because in that baseball-style arbitration where you have a final offer, you have some specific guardrails or specific criteria that the arbiter is referencing, which is acuity, complexity, quality, previous contract rates, et cetera. But the key thing is that you've got two numbers. Those two numbers are one, you only have to choose one of them. You're not trying to pick a number somewhere in between, and it forces both sides to be fair.
Another question, Dr. Friedman. When New York implemented their solution, many feared that it would allow providers to drive up prices exponentially. Has that been the case?
No, it is not. What we've seen in New York is that providers are charging reasonable rates when they go to arbitration or they go to negotiation, and insurers, in fact, are paying at reasonable rates when those bills come in, for the most part. What's happened is that it's taken care of outliers, the extraordinary cases where people, and there are folks on both sides abusing the system. It has taken care of those.
Gentleman's time has expired. The gentleman from Virginia, Mr. Griffith, is recognized for 5 minutes for his questions.
Thank you very much, Madam Chair, and I apologize to the members of the committee. I've been bouncing between this one and the others. You've heard several other people say, and the other one is now over. But I did want to ask some questions, and I have, during the time I have been in the room, I have learned a tremendous amount, and appreciate you all being here. Mr. Sherlock, I'm going to ask you some questions about air transport. And it comes up, and I don't know whether the person that told me this is accurate or not, but I had a child in my district recently that was hit, and I know that they were airlifted to a hospital. About a week later, a constituent comes in with a whole laundry list of things, and one of them was, he says the family was charged $40,000. So that's where I start my questions with that just as a backdrop. But you opened your written testimony by referencing the Association of Air Medical Services support for the Air Ambulance Patient Billing Advisory Committee in the 2018 FAA reauthorization. Now, we don't have jurisdiction over that, but that means that a lot of our members of this committee may be less familiar with how that consensus language became law. Can you share with us the background of what led to the establishment of the advisory committee? And while you're at it, also tell us, has it actually been established? Because sometimes we put it in law and it doesn't happen. And have they started meeting?
Thank you for the questions. First, the Air Ambulance Patient Advisory Committee was put into effect because currently the Department of Transportation has a Consumer Protection Division that has the ability to investigate and look at how charges were determined and hold patients harmless. We agree with Ms. Wilkes that the medical needs of a patient should be first, and no patient should be in the middle of a discussion between payers and providers. That committee also includes representative of Health and Human Services, and so it's a joint committee. We would encourage Congress to urge them to get that committee seated and started. They have a requirement to investigate and recommend solutions to hold patients harmless, as well as to look at the economics of the air ambulance industry, and we think Congress would be well served by that. We also don't believe that, our industry doesn't believe that any patient should be caught in the middle. We've supported federal legislation that would increase 100% transparency of the industry by mandating 100% industry reporting of comprehensive cost data that would then be turned over to the Centers for Medicare and Medicaid, which would then be used and analyzed to actually rebase the Medicare rates for air ambulances at the cost of providing the services. That Medicare gap is the single largest driver in raising costs in the air ambulance industry and in balance bills. When you get those comprehensive data reported and they get analyzed and they become public data, then everybody will see where everybody falls out on the cost curve, and in addition to that, quality of care, where everybody will see where programs fall out on the quality of care curve. So when those become public data, that will increase both the transparency and the accountability of the industry, and we support that legislation that was introduced and sponsored by Mr. Ruiz and Mr. Johnson, and actually co-sponsored by Chairwoman Eshoo in the previous Congress.
And my understanding is currently the Medicare and Medicaid reimbursement is somewhere between $3,000 and $6,000, but the average for somebody that's paying without that coverage is about $26,000. Is that accurate?
The median cost of a helicopter air transport is $10,199, according to a study conducted in 2017. If you look at the cost of uncompensated care, because Medicare pays less than 60 cents on the dollar of that $10,199, about $5,998, Medicaid pays significantly less than that, less than $3,500 on average, and the uninsured pay about $350. Those three groups make up 70% of air medical transports. So when you take that cost of uncompensated care and you add it to the median cost of $10,200, that's the average charge of $36,000 that the representative from New Mexico referenced earlier. When those kinds of situations happen, no one in our industry wants to see a patient or their family placed in jeopardy because they've just had a health emergency. Our members will sit down with each individual and their families and work out a solution tailored for them. And a comment that was made earlier today about a snake bite victim that was transported across state lines, in fact, that was resolved, and that patient and their family received no balance bill in that, because our programs will work with each patient to develop a solution tailored for them.
All right, I appreciate it, and I yield back.
Gentleman yields back. Now would like to recognize the gentlewoman from Delaware, Ms. Blunt Rochester, for 5 minutes of questioning.
Thank you, Madam Chairwoman. And I think you coined a new term, shock billing. I wrote that one down. I want to also thank the witnesses, especially for your flexibility and your patience with all that many of us have been through today. But thank you for your time. Investigative reporting by journalists like Sarah Cliff for Vox and Kaiser Health News and NPR's Bill of the Month series have really shed a light on how patients, often at their sickest and most vulnerable, get stuck in the middle of payment disputes between providers and insurers. We've heard countless times today that patients shouldn't serve as an intermediary between these two entities. Holding the patients harmless should be the crux of any legislative solution that Congress puts forward. And I was really encouraged today by the discussion, the fact that there seems to be bipartisan and across the panel support that something needs to be done, and it needs to be done now. And this No Surprises Act also maintains that standard. In a May 2018 article by Sarah Cliff, a 34-year-old man received a surprise $7,924 medical bill from an emergency oral procedure after a violent attack the night before. Cliff noted that this bill was a case she saw regularly, patients who had large medical bills because they went to an in-network hospital but were seen by out-of-network doctors. The good news is that the entire bill was reversed. The bad news is that it was after the news article. So, Ms. McAndrews, I'm sure I know the answer to this question, but should patients have to rely on news coverage of their surprise medical bill in order for them to negotiate a lower bill?
Thank you very much for that question. And of course, the answer is absolutely not. And we indicated in our testimony that this problem has been going on for a very long time. But unfortunately, before consumers had advocates like reporters or their members of Congress to reach out to, a lot of consumers don't know to take that recourse or are too sick to take that line of recourse and are sometimes paying these bills, going into bankruptcy, going into debt. And so there should be policy in place that automatically protects consumers so they don't have to take these great lengths to get protection.
Thank you. I've also heard stories from emergency care physicians in my state where patients delay their care because of their concerns about surprise medical bills. Ms. McAdams or Ms. McAndrews or any other member of the panel, have you seen this where people are afraid to get care because they're afraid that they might receive a shock bill?
I would like to respond to that because it just happened within the last couple of months for my family. Thomas fell at school and broke his arm. And I legitimately did not know where to go. I didn't know whether to go to the urgent care or to the ER. So ultimately, we went to urgent care, got an x-ray. Sure enough, the arm was broken and ended up in the ER because of his chronic illness. That delayed his care. He was in pain for a number of hours while we were making that transfer.
Thank you. I want to transition to the question of transparency. Even when patients are diligent about making sure that they're receiving in-network care, they can still end up with a surprise medical bill. Often this is because they're unable to ultimately know if every physician involved in their episode of care is in-network. And I'm going to direct this to Dr. Zaafran. How can we increase transparency for consumers and make sure that they're able to easily find out what providers are in-network?
Thank you. So the short answer to that is that the insurance industry has to have directories that are updated in a real-time fashion. Again, there is no such thing as an out-of-network provider. There is a provider who may happen to be out-of-network with that specific product. So the only one who knows what that product is, of course, the patient and the insurance carrier, and they're the only ones who really have the information as to whether they're in-network or out-of-network.
I just want to close by saying I commend the committee and everybody who are involved with this. I recall when my husband passed away unexpectedly to receive bills, not when I was living in Delaware. You're already going through a tough time, and then to be surprised with these kind of unexpected costs are unacceptable. And I'm glad to see in this committee that we are looking at this, we're taking leadership, and that there is a sense of urgency because people are counting on us. Thank you, and I yield back.
The gentlewoman yields back. I now would like to recognize the gentleman from Georgia, Mr. Carter.
Thank you, Madam Chair, and thank all of you for being here. I know it's it's been a long day, so you're almost home. Just hang in there. You know, this is a very complex issue. We all understand that, but it's a very important issue. And Ms. Wilkes, I want to thank you for being here today and for your testimony. It's certainly compelling and certainly something we have to work with. Full disclosure, currently I'm the only pharmacist serving in Congress, and I have experienced the wrath, if you will, of the insurance companies. At the same time, I understand where they're coming from, too. And that's what makes it such a complex issue. One of the things that we deal with, and Dr. Zaafran and Dr. Friedman, I'll tell you that we all use the old adage that misery loves company. I'm in misery with you. So, you know, it's tough. I deal with PBMs. And, oh, by the way, what we have in common with PBMs is that they're owned by the insurance companies. So, nevertheless, one of the things that we have in pharmacy, though, is, you know, we have any willing provider. And that is if we're, you know, quite often we're shut out. Patients don't have a choice. If they come to me and I'm at a network or I'm not a member of that network, they can't get the prescription filled under their insurance. They'd have to pay for it out of pocket. But some states have laws that say if you're willing to accept what the insurance company is willing to pay, then you can participate. Well, the insurance companies don't want to do that because then they can't go out and build networks, is what they're telling me, because if anybody's going to accept it, then the companies, the pharmacies that are agreeing to be in that network and bidding to be in that network aren't going to get the volume that they are anticipating. It seems to me like this is just the opposite of what the economics are on why you would not want to be a part of that. Can you help me out, Dr. Zaafran, as far as the economics of how that works when you have the insurance company pay and you add a network like that?
So what I would first say is, again, in our organization, Physicians for Fair Coverage, 90 to 95% of us are in network. We want to be in network. We strive to be in network. We negotiate with insurance companies to be in network. In many instances, the times we're out of network is when it's a patient coming from another state. Or in some instances, we're in network with everybody, but there may be one specific plan or one provider or one carrier that is not really negotiating with us in good faith. Typically, most of them are, and we're in network with all of them. It is in our interest to be in network. The volume, the cost of providing that service, the cost of billing, the timeliness of payment from the insurance carrier, these are all factors that actually strive to make all of us as physicians want to be in network because it's so much easier.
Okay, well, let me ask you, Dr. Friedman, and by the way, yours is somewhat of an unusual circumstance. Yours is kind of an outlier, if you will, because as you say, you're in Orlando and you got a lot of people coming, but even more so, why we should be addressing it. Can you speak to the economics of it?
Well, I think for all emergency providers, whether you work in Orlando where I work or anywhere else in the country, we want, as Dr. Zaafran has mentioned and I have as well, we want to be a network. We want to take care of patients. I became an emergency physician to take care of patients. I didn't go to medical school to do billing. I frankly didn't think I would ever be in Congress talking about anything like this. We want to take care of the patients, and we would like the back end, the business side, to take care of it as well. In emergency medicine, we have a unique circumstance in that I can't tell the patient what the cost is going to be. I don't even know if they have insurance when I take care of them. So everything happens afterwards. I can't identify the insurance product. Sometimes my billing company doesn't know if they're out of network for a couple of weeks because it is so difficult. I have a United Healthcare card. Nothing against United Healthcare, but all it says on there is what my copay is.
Right.
That's it.
Right. And by the way, United Healthcare owns their own PBM, and they also own their own mail-order pharmacy.
Right, but I don't know where I'm in network with that card.
Right.
And, you know, if I'm in D.C., if I try to find a doctor,
sure,
I have no idea.
Well, and thank you for that. And now, before my time's about up, but Mr. Nichols, I have to tell you, out of all due respect, sir, the chair lady asked you a question at the first of this hearing that I thought you tried to dodge. And I will tell you that whereas I respect the Hospital Association,
I do think you have more of a responsibility to be a mediator, if you will, between the insurance companies and the providing physicians to try to help them to avoid the surprise billing that we're seeing. So I think that is a responsibility that I hope that you will that y'all take seriously, and I hope that we can count on you to do just that.
Definitely, I know that time's expired, but I would totally agree with that. We do our best to work with the insurers and the physicians.
Well, as I say, I thought you avoided her question, but nevertheless.
I could try
And the
to get
last
it
thing
right.
is, one thing about the Pallone bill that I do like is that they would let states decide, because we do know that there are states where it's working what they're trying to do. I hear New York is working with arbitration, and I hope that we don't precede that with any legislation that we pass, and I yield back.
Thank the gentleman, and he yields back. I just would like to add something to Mr. Nichols. This business of antitrust and what the Hospital Association keeps referring to it, I think that when you answer members' written questions, that you take another look at this. I don't understand how antitrust can be thrown around in this, but maybe it's because I don't know enough about it.
Be glad to answer
We
that.
have, thank you.
I'd be glad to answer that. Thank you.
Sarbanes still here? No? He left? No one else?
We'll let Mr. Nichols speak to that. Are you willing to speak to that now, the antitrust issue?
If he can, in a succinct way.
I'll do my best. The antitrust concerns we raise goes along with so-called network matching, where requirements, which is not in the Pallone-Walden bill, but I wanted to mention it because it's in other bills, where there's an attempt to put a requirement on hospitals to make the doctors be in network with them, with us. And we believe that that would raise, I think, a physician who would be forced to adhere to a third-party contract could very easily come after us on antitrust grounds. We're more than willing to work with them to
I don't get that. I mean, I chaired a hospital board of directors. We had, it was our own county hospital. It was a public hospital. We had docs from the community that worked there, and the contract that we had was for the ER and those docs. And so I don't know what you mean by you can't do this, you can't do that. You already have all these different groups that you contract with.
Right.
I mean, the out-of-network starts when they're in your network.
If we employ the docs, then that's not a problem. There's no antitrust concern of any kind. The concern is, and again—
What's the difference between employ and contract?
Well, if it's contracted, then if they work for us, one of the things we do is if we're in a network, you're in a network. That's required. The issue is we can persuade, we can try to work with the physicians to get them to do what I just described, but the issue that concerns us is what if we try to—
When was the last time you tried real hard and it failed?
Say that again, I'm sorry.
When was the last time you tried real hard and it failed?
I could get you examples of people, my members, who have tried to do that. And again, my view is, our view is—
And then was there the threat of antitrust as a result of trying to work it out?
There have been, I can give you examples where there has been threatened litigation if you tried to do that. I can also give you examples of where it worked, where we were able to persuade the doctors.
All right, well, I'm going to have several questions for you. I appreciate it. And now I'd like to recognize the gentleman from Maryland, Mr. Sarbanes, for his 5 minutes of questioning.
Thank you very much, Madam Chair. Thank you all for being here much of the day. Your perspectives, obviously, on this issue are very valuable. You've got a lot of expertise you brought to bear with respect to this issue of surprise billing, and it's incredible, I guess, but not totally surprising that it's affecting as many as 1 in 7 patients in America. We all hear stories from family members and friends of this kind of gotcha moment that they face. And the thing is, even when patients are trying to anticipate this situation and do their homework to make sure they're getting the services in network and so forth, they can still get caught short and be surprised with the medical bills. And you know, these can total tens of thousands of dollars. I mean, it can wipe somebody out. Again, even though they're taking every precaution that they can manage to do. And as we heard from Ms. Wilkes, the impact of those bills, the examples of how devastating it can be to patients and their families is very sobering. I'm glad we're here talking about different kinds of responses to this problem and solutions. I'm sort of attracted to the No Surprises Act right now because I think it achieves that balance in a way that works best for patients, which is the perspective I'm bringing to bear for the most part here. And it would take them out of the middle of these out-of-network payment processes, set that benchmark rate for out-of-network payments, as you know, to resolve payment disputes between providers and insurers. Maryland, the state I represent, has chosen to address the surprise billing through this benchmark approach, and in 2011 implemented that system, which requires out-of-network bills to be sent to insurers and not to patients, and defined a formula that could be used for those out-of-network payments. The goal was to reduce patients' financial burden while still paying providers at an adequate rate, maintaining network adequacy. To monitor the success of the benchmark plan, the Maryland Healthcare Commission was looking at out-of-pocket costs, reimbursement rates before and after the implementation of law to see what the effect would be. Ms. McAndrew, would you agree that the rates agreed to between providers and insurers for medical services are in fact a consumer issue, and would setting a benchmark rate for out-of-pocket costs go a good way towards protecting patients from unexpected and exorbitant medical bills?
Thank you very much for that question. We absolutely do believe the rate between insurers and providers is a consumer issue. Consumers, of course, ultimately do bear the cost of healthcare, and they bear them both out of pocket, which has been the crux of our discussion today, but they also bear them in their premiums. And so if the legislation to affect surprise bills ultimately inflates healthcare costs in the system, that will affect consumers' premiums. And so we do prefer a benchmark methodology. We believe that is what will ultimately lower costs the most for consumers. Other methods can be better than the status quo, but they can have less of an effect on lowering costs for consumers. And costs are rising and rising. We see that voters care about that more than anything else about healthcare, and so it's important to us as a consumer advocate.
That's certainly my perspective. And as a matter of fact, the Maryland Healthcare Commission, from its study, found that in 3 years after implementation of the benchmark system, the total amount of out-of-network payments decreased from 20% to 11%. And those patients that still had out-of-network charges saw their total spending decrease as well. So I think it shows the benefits of that. Some groups have expressed concerns that setting a benchmark rate could lead to providers leaving networks and the networks shrinking over time. Have you seen evidence of a kind of dramatic negative effect that way, or not really?
We have absolutely not seen evidence that benchmark rates will cause problems in networks. Our colleagues in California who have worked very deeply on the implementation of this law have not reported any such effects. I would caution making any conclusions about the California law since it's so early, but I think you've also presented very strong evidence from the state of Maryland. And I would also acknowledge that the reason this law is being implemented is because right now people can make very large amounts of money by going out of network through balance billing. And so once that's no longer possible, that is a very big deterrent for remaining out of network. And so I think that will have a very positive effect on networks.
Well, I appreciate that, and what you just said certainly aligns well with the experience in Maryland. Because again, from the study that was done in the monitoring, the Maryland Healthcare Commission found that although out-of-network payments decreased, as you would expect, in the 3 years after a benchmark was set, overall provider participation in those networks did not show a decline. So I think there's a lot of promise there in terms of the response we need to see to this surprise billing issue. With that, I yield back my time. Thank the panel.
The gentleman yields back, and I think that is it. I don't see any other members on either side. On behalf of all the members of the subcommittee, I want to thank the witnesses. You've been patient. You've been here since before 10. It is now, well, you've been here for 4 hours. And we're very grateful to you. You've had to field some tough questions, but that makes for a good hearing. None of it is personal, and we have to, I always first try to remind myself that that there has to be a great deal of friction, wave action for the sand in the shell to produce a pearl. Now, the pearl we're looking for is good, solid legislation for consumers in the country. So that friction in terms of tough questions and testing each case the best we know how, the best we can, is to benefit the American people. So we all thank you. I want to remind members, whoever's left in the room, that pursuant to committee rules, they have 10 business days to submit additional questions for the record, to be answered by the witnesses who have appeared, and I ask each witness to respond promptly. We need that in terms of our considerations here to any such questions that you may receive. So I don't think any of you are going to purposefully drag your feet, but I think it's worth underscoring that we would like a timely response. Now, I'd like to ask unanimous consent to enter into the record the following. The statement from the National Observation Stays, STAYS Coalition, statement from the American Medical Association, statement from the College of American Pathologists, statement from the Association of American Medical Colleges, statement from the American College of Radiology, statement from Blue Cross Blue Shield Association, from the Partnership for Employer-Sponsored Coverage, from the American Federation of State, County, and Municipal Employees, a statement from AARP, and from Business Group on Health, SEIU, United Healthcare Workers West, and Blue Shield of California. So I ask unanimous consent to enter this into the record. I hear no objections. And at this time, with all of our thanks, the subcommittee is adjourned. Thank you, Doctor.